that, it was certainly a challenge at first to get buy-in, and I've sort of broken down my comments into three categories, if you will, based on what I received yesterday in terms of kind of how to approach this. And I'll be brief in my remarks. I won't belabor things. So the first piece of it is, how do you get buy-in? How do you get buy-in from your colleagues and your teammates to sort of follow these guidelines? And what I found is that getting resident, because we're a teaching program, so we're a 330 bed community hospital, full residency programs in 19 different specialties. We're a level 2 trauma center. We're a primary stroke center, PCI, all of that stuff. So I find that residents are hard, okay, to get buy-in with, and attending physicians are easier, but they too can be hard because, they oftentimes have old habits that are hard to break. I've been doing this for 34 years, and you get into certain routines and comfort levels that sort of dictate how you practice day to day. I'll just share this quick story. My now 26-year-old son, when he was born with a terrible congenital heart problem, and I'm thankful to the University of Michigan and the incredible congenital heart center there, who saved his life. But the way I approached children prior to Alex's birth and after Alex's birth is so significantly different, because your personal experiences feed into what you do in your clinical life. And if you don't think that that's true, I would caution you to really understand that. We all have inherent biases and things that we do. So what I found to really be helpful in terms of getting our team in line and improving, and to be honest, I'm personally not happy with our performance on this particular measure, because in my opinion, we should be at like 85 to 90%. I think that's very realistic. And I think if not for a residency program, we probably would be close to that. But nonetheless, we got copies of the laminated cards, and I literally taped these cards on the side of every workstation in our emergency department, because I thought, if it's right there, how can you not see the card and go, oh, this patient doesn't really need to have a CT? So that was just one of many things that we did and continue to do as it relates to these types of measures, not just head CT for adults, but also PCARM for kids, now the PE measure, and others. Frequent presentations at resident conference is another avenue that I have undertaken. And I find that this is one of those things you can't just do one time and put it on cruise control. There's got to be repetitive reinforcement. So I try to get on the conference agenda at least, twice a year, if not 3 times a year, because you've always got some house staff that are coming and going, and they do out rotations, or we send our ER residents to Baltimore shock trauma for 2 months during their training, and they always come back with bad habits because they do it differently there. So that's sort of a touch point for me. I always kind of reach out to those, because it took me some time to figure that out. But now when I've got my second year residents coming back from Baltimore, I always have a quick conversation with them about, I'm glad you had this opportunity. I'm sure you learned incredible things that you're not learning here, but remember this. Department meetings. We have bi-monthly department meetings where all the attending physicians are meeting. And one of the things I'm thankful for in regards to this pandemic is that we now do all of our department meetings by Zoom. And my attendance at department meetings is now incredible. Whereas before, when we had the kind of schlep in early in the morning, You've always got a couple people working. You've got people coming off nights. They don't want to come. Our attendance, because it's so easy to attend now, is significantly better. And that gives me more touch points where we can have a conversation. And I have medic measures as a line item in our bi-monthly agenda. We talk about it every other month. Where are we at? How are we performing? What are some of the things that are being, what are some of the problems you're encountering, and so on, so that we can try and address those. And I think that that's been really, really helpful. In terms of the challenges, which is my third of three sections, if you will, I've kind of mentioned that obviously old habits die hard, old ways of thinking. And of course, there's always that fear of litigation. I hear that relatively frequently. What if I have that guy who's been drinking and falls and whacks their head and he had a loss of consciousness? I think I should scan that person. And they're not on an anticoagulant. And if you really look at the Canadian head CT rule, it doesn't meet, right? They're sort of back to baseline. But I find that alcohol and drug involvement is always a complicating factor for clinicians to decide, should I or should I not get that head CT? This has been an ongoing conversation, and the GCS being lower or not. So if you've got somebody who's drunk, but their GCS is normal, that's always a problem point for a lot of clinicians, because they feel very uncomfortable with not scanning that head. So that's a challenge. And I don't necessarily have a great answer for it, but what I will tell them is, if you really are that uncomfortable, obviously we're not looking for 100%. That's where I think that 10 to 15% should fall in, right? And I always say to them, but I want you to really document this well. Explain in your medical decision-making note why you were uncomfortable. What were the elements there? Because maybe, just maybe, we can find a good reason why it's not a fallout based upon that documentation, as opposed to just hard and fast rule of Canadian head CT. Make me understand what your thinking was at that moment in time that led you to say, yep, I'm going to click on that head CT and order it. I also think another challenge is the fact that we're a trauma center and that we're a stroke center. So we frequently have patients present to our triage, and we have empowered our triage nurses to be able to order a head CT before a physician sees them. Now, there's criteria for it, and it's mostly for stroke patients, but I do catch quite a few every month that slip through because the patient fell, hit their head, and had an LOC reported. And based on that, the triage nurse went ahead and ordered the head CT. And it wasn't really a stroke presentation, it was a head injury presentation. And again, if they're on anticoagulants, aspirin, Plavix, Coumadin, those are not included, and those are reasonable. But again, that's another challenge. I also think that, understanding a loss of consciousness isn't necessarily germane to the Canadian head CT rule, and having some dialogue around what does that mean? Is it important clinically? Just because they say I was unconscious, we all know that frequently patients will say I was unconscious, and then you really kind of dig into it, and how do you know if you were unconscious? If you're unconscious, you don't know it. So how do you report it? I think it's a little bit different, obviously, if there's a family member there and they allege that, so-and-so was completely unresponsive for a minute or two or three or four or however long it was. It's usually, embellished, but that too is a challenge. And that's something that I would encourage all the other departments to really focus in on and address, because again, when I look at our fallouts, it's almost always because of drugs and alcohol or a loss of consciousness. and that level of discomfort because of some unfounded fear of litigation, that if I don't do it and there's a bad outcome, you know, Jeff Feiger's coming after me. So that's something that is problematic. And then the last challenge is dangerous mechanism. And I personally have a problem with this one. I've always had some difficulty, and I'm looking at it right now because I didn't want to misquote, but you know, dangerous mechanism is really defined as pedestrian struck by a car or vehicle, an occupant ejected from the vehicle, or a fall from greater than 3 feet or 5 stairs. I mean, I would argue that there are other dangerous mechanisms that probably should be included, but nonetheless, that is another challenge point, and I think that's a big reason why you have fallouts. My last comment would be in terms of what are my wishes? What would I like to have that I don't have right now to try and make this even more successful? And I think the biggest thing is that, you know, when we have a bad case, whatever that might be, it could be unrelated to a medic measure or any other PQRS measure. What I find is most impactful is when I can sit down with a clinician and have a conversation and some dialogue about that case, and you know, tell me what you were thinking, share with me kind of where you were at that moment in time, because we all know when you're at the bedside, it's a lot different than when I'm looking at a chart the next day and go, oh, it's obvious it was this. You know, it's not so always so obvious, and I give a lot of latitude to that, but I think it's an ideal opportunity to really learn something. I know that when I review cases, I always learn something, even though I wasn't involved clinically. And I try to point that out to whether it's a resident I'm sitting with or one of my partners I'm sitting with, and saying, you know, there's an opportunity here. I don't think you did something bad or wrong, but could we do it better next time? So my wish would be that if I could get the data faster of the fallouts from month to month, because frequently I don't get it until 2 or 3 months later, right? And it's kind of hard to have that same impactful conversation when I call somebody and say, hey, you remember that lady you saw 3 months ago who fell and she hit her head and she was unconscious, but she's not on thinners and you got a CT? And they're like, well, it sounds like 50 other patients I saw in the last 3 months. No, I don't remember it specifically. And I think that that is a lost opportunity. So, you know, my wish would be to, you know, get faster feedback, even within a month. I think that would be awesome to be able to have that conversation, because the shorter we can make that gap between the clinical experience and the feedback experience, the greater the impact in terms of maybe they think about it a little bit differently the next time they encounter that situation. And you know, it works out differently. So um, that's what I've got to share. I'm happy to field any questions, and I appreciate the opportunity to be involved with this. Thank you.
Thank you so much, Dr. Vieder. That was wonderful. And just, I guess we need to open it up real quick. Does anybody have questions for Dr. Vieder? If not, we can kind of, we'll let Dr. Krupp take over, and we can always ask questions towards the end as well. But if anybody has something they want to ask now, feel free.
Remembering that you can unmute yourself, and
Yes.
also please use the Q&A at the bottom of the screen, and we can also feed them that way as well.
This is Keith. I have a question for you, Sanford. I'm curious about, like, did you have a pre-existing process? You were sort of mentioning that you follow up with your colleagues about these cases that may fall out or you know, look like they were inappropriate CTs. Did you have a pre-existing process for that, or did you create that process after joining Medic?
No, I did not have, specifically not to CT or any of the measures that we're currently involved with. That was after joining Medic, and I think this is our 4th or 5th year now, roughly.
Yeah.
You know, it's been a learning process for me. I'm a pretty simple guy. I'm not a researcher. I'll be the first one to admit it. I'm a clinician. You know, I'm sort of one of those go to work clinician guys who happens to also be the chair of the department. And I like to lead by example. I think that that's, you know, the best way to do it. And, you know, having to learn and understand that the Canadian head CT rule was a evidence-based clinical decision tool. Even though you share that kind of information with people, they still struggle with it. And again, for us older guys who've been doing this a long time, where, you know, a lot of these rules are newer and or evolving or developing or changing and improving, you know, it's probably a little bit harder for us to change our practice habits. But no, I did not have a pre-existing process. I definitely had a pre-existing process for patient complaints and or you know, an internist calls and says, you know, you guys screwed up on this admission because of X, Y, and Z. You know, the fishbowl, right? The fishbowl of emergency medicine, I call it. And I certainly had, you know, pre-existing process of the way I liked to approach it. I never do it in a critical way. I do it in a supportive way. I get a lot more with sugar than with spice, and I get buy-in from people when I do it that way. Because I'll even say, you know what, I've done the same thing. I've screwed up before. I learned from it. This is what I did when I did it. I think those are powerful messages that get people to slowly change over time. Sometimes it can be with just one episode, but other times it does require repetition. There might be nuances between one case and another and that kind of thing. So I applied that same sort of process I had previously used to the medic measures and now do it with that.
Thanks.